My name is Mary Rodgers. I happen to be the chair of the American Heart American Stroke Association Nursing Symposium, State of the Science Stroke. With me is Brenda Johnson.
Hi, again, I'm Brenda Johnson. I am an associate clinical professor at the School of Medicine at Johns Hopkins Hospital, and I'm also the assistant director of the Comprehensive Stroke Center.
We are really excited to be able to talk to you about the nursing perspective for the new 2026 Ischemic Stroke Guidelines. So I have Brenda here as one of the authors.
Okay, thanks, Mary.
Brenda, when you're looking at the newer guidelines, we see the mention of stroke units. Could you tell us about that?
Yeah, so that is a new 1B recommendation. Stroke units have always been in place for stroke centers. The difference in the recommendation now is that it's a requirement, and this is good because a lot of hospitals are primary and comprehensive stroke centers, and it's basically good for the patients because the patients will be put in a designated area where they're going to be treated by nurses that have clinical expertise in stroke care. These nurses will have education specific, again, to stroke.
So the difference then being, it used to say that we could have designated beds, but now we're talking about cohorting them into one specific area, as you said, to increase that level of expertise of nursing care that's being provided. That's wonderful.
Yeah, that is wonderful. I love that recommendation.
One of the other areas that I noticed as I was reading through the new guidelines was the nutritional section. Can you give us some information on the nutritional section?
Yeah, that's a new recommendation as well. As we know that stroke patients, need to be fed, and the new recommendation now is also a level 1B recommendation, and it's recommending that patients be assessed with a validated screening tool within 48 hours of being in the hospital.
How would you suggest that they go about getting that validated tool?
I think that stroke centers should have a nutritionist as a part of their multidisciplinary stroke group, because the nutritionists have a level of expertise, of course, in nutrition, and they can partner with that nurse or that whole multidisciplinary team to ensure that that patient is getting the right level of nutrition, because as we know that stroke patients can be malnourished and this can impact their recovery.
Yeah, requiring that or suggesting it as that level 1B evidence within the 48 hours, again, is something that's brand new for everyone.
Yeah.
So that's really exciting. The other area that I saw within the guidelines is talking about the pharyngeal electrical stimulation for the dysphagia.
Yeah, so that is a new recommendation, and that recommendation is a level 2A recommendation. And that recommendation came about because when we were writing the guidelines, we looked at several clinical trials, one being the FADER trial that came out, I think it was back in 2020. And I think this is very good for the patient because this paper showed that it decreased dysphagia severity, it decreased aspiration, and it decreased also hospital length of stays in stroke patients.
So there's only a benefit to it. It sounds like that's wonderful. That's wonderful. One of the big area of changes and discussions that are current in the current guidelines is the discussion of the pediatric population.
Yeah.
So how did that come about? And what do you think that stroke coordinators should be focused on in looking at that section?
The pediatric section is very new, and I'm happy to see it in the guidelines. So I think this is going to be very good because, as you know, Mary, we have a lot of hospitals that are rural. We have a lot of, acute ready hospitals, primary centers that are not equipped to take care of that pediatric stroke patient. But once they get that pediatric stroke patient into the emergency room, those nurses need training on how to recognize a stroke in the pediatric population, although the stroke symptoms are the same, but getting that patient in and out is what's important here.
Yeah, you mentioned in and out. So working with the tertiary centers or the children's hospitals, those pediatric neurologists, to help guide that treatment while they're in that emergency room in either the rural or the urban setting that doesn't admit those patients. Sounds like it's really critically important.
Yeah, that's very crucial. And I think ahead of time, because of these new guidelines, that those nurses should maybe partner with some of those hospitals and, at least be able to identify where that pediatric patient will be going.
Yeah, almost like a ad hoc committee member, if you will.
Absolutely.
So help in the beginning. Let's talk about this. What's the evidence? That's a wonderful way then too, as you said, to increase the emergency room nurses' expertise in recognizing. You would also think that pediatric nurses would have some type of stroke education then as well. Would you agree or no?
I think it would enhance their clinical knowledge, and they should have that level of education to be able to take care of this pediatric stroke patient.
Excellent, excellent. Brenda, thank you so much for being on the writing committee. It is just wonderful to be able to see and discuss these new guidelines. There's been a lot of excitement around these guidelines. So having you there and Ann Alexandroff there as our representatives, thank you so much. Truly appreciate it.
Thank you, Mary. Thank you. Happy to be a part of it.